Good evening, everyone, and good evening, Dr. Chandrakanth. Also, so I just welcome all of you for this Pfizer-hosted webinar, where we have a Dr. Chandrakanth M V as a speaker, who is a consultant medical oncologist from Narayana Superspeciality Hospital, Kolkata, and he is today presenting on the right treatment for the right patient in mRCC. So, without wasting much time, I will hand over to Dr. Chandrakanth. So, sir, over to you.
Thanks, Dr. Ishan, for the kind introduction. So, as the title is very correctly mentioned, we are speaking on right treatment for right patients in mRCC. And good evening, everyone. And I would thank Pfizer from the outset for providing this opportunity. So, the moment we say metastatic RCC, uh, uh, if if I were to speak regarding metastatic RCC around a couple of years before, this topic would not have been there. So just in the matter of 2 years after immunotherapy has come into light, now we speak of right treatment for metastatic RCC. So if a patient of metastatic RCC were to come to me 2 years before, I would have written sunitinib or pazopanib for each and every patient, irrespective of whether they belong to good risk, poor risk, intermediate risk. But now we have to before. So now the era is before we start systemic therapy for a metastatic RCC. It is not just enough if I know that it is a clear cell RCC or a non-clear cell RCC. I also need to know what is the risk stratification. If I am not doing risk stratification before starting therapy in a metastatic RCC in the present era, I will be doing an inferior therapy for these set of patients. So risk stratification is one of the prime step before proceeding on to treatment as far as metastatic RCC is concerned. So going on to the prognostic factors. So these are the clinical prognostic factors we have for metastatic RCC. There have been number of schools of thoughts and number of institutions who have come up with risk stratification protocols, right from MSKCC to IMDC to many other. So this is how all about IMDC and MSKCC are the ones. So not all metastatic RCCs are same. We have certain criteria. We can pick them. We can classify them into favorable risk, intermediate risk, or poor risk. You can see a very simple classification. Favorable means none of the high risk factors, and intermediate means if there are one or two risk factors, and poor is if there are three or more risk factors. And these do not just help us to prognosticate, but they also predict what treatment I'm supposed to give. Well, if you look into the IMDC and the MSKCC criteria, so IMDC is having a lot of lab parameters. So you look into the IMDC criteria. So basically, IMDC is the one that we are universally using in majority of the recent clinical trials, because IMDC is the one that is looking into finer aspects of risk stratification. So we look into IMDC criteria. So number one, we have the performance status of the patient, which is one of the most important prognostic factors in oncology. Then we have time from diagnosis to start of therapy. These are the two important factors of the host. And then you can see the disease-related factors like the hemoglobin level, the neutrophil, the platelet. Then we have the uncorrected calcium level. And the LDH, which is there in the MSKCC, is excluded from the IMDC criteria. So we need to just remember 6 important factors: the performance status, which is the host factor, and then the time from diagnosis to therapy, hemoglobin, calcium, neutrophil, and platelet. These simple blood investigations, just a CBC and a calcium is sufficient. to risk stratify a patient with metastatic RCC. So without doing risk stratification, we should not proceed for systemic therapy in the present era. Previously, we used to have poor risk versus intermediate or a good risk. If it were to be poor risk, temsirolimus was there, which used to give some overall survival benefit. But it was a very toxic drug, was not practically feasible. So irrespective of, so the risk stratification was mainly a theoretical phenomena. If I had to speak a couple of years before, it has to be just there on the paper, but it did not have any practical implication. But now, after the immunotherapy trials, they have come up with the concept that if it is good risk, a single TKI is enough, a or a pazupanib is enough in the first line setting. If it's an intermediate or a high risk, then I need to put in immune checkpoint inhibitors in this particular setting. So if there is none of the risk factors, single agent TKI is sufficient. If there is presence of intermediate or poor risk, then I need to put an immune checkpoint inhibitor in place. Not only that, uh, of course, the favorable risk factor patient will survive for long. So not only it will help me in prognosticating, but also in selecting a proper agent. So not only in selecting a proper immunotherapy or TKI, it will also help me in picking up which patients have to go for cytoreductive surgery. The renal cell carcinoma is one of the diseases where even if you have metastasis, you are not worried about the metastatic sites. You will go ahead and do a cytoreductive surgery. So this is one of the paradox in oncology, where metastatic disease, I am not worried of mets. I am happy removing the primary. This was uh, 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 so this is in contrast to the breast cancer or other cancers where in a metastatic disease we are not supposed to touch the primary. I mean, it is not beneficial, but RCC is where if you do a primary cytoreductive, if we do a cytoreductive nephrectomy, then it is beneficial. So again, this risk stratification helps us to pick which patients we are supposed to subject to cytoreductive nephrectomy. So if the patient has none of the risk factors, if they belong to the favorable group, that particular subset of patients do benefit with cytoreductive nephrectomy. And if you look into this intermediate, so poor risk is clear. If I have three risk factors, obviously it's going to be a poor risk and the patient is not going to live long. You need, so cytoreductive nephrectomy is not beneficial. Immune checkpoint inhibitors have got a great implication and use in poor risk. The moment you come to intermediate risk is not a single category. Even though intermediate risk has two risk factors, if intermediate risk has only one risk factor versus two risk factor, there is a difference. Low intermediate is where if I have only one risk factor, this set of patients may benefit from cytoreductive nephrectomy. So basically, practically, we have four divisions. One is favorable, where there are no risk factors. Intermediate, one or two risk factors. In intermediate, I have low and high intermediate, where one risk factor, two risk factors, and poor if there are three or more risk factors. So this is one of the most important slides in understanding the further evidences which I'm going to speak in coming half an hour. So IMDC risk stratification, favorable risk TKI alone is sufficient, cytoreductive nephrectomy is beneficial. The moment I come to intermediate and poor risk, I need to put in immunotherapy at some point in the upfront setting, either immuno or an immuno TKI. I have to put in with it is intermediate or poor risk, and if it's low intermediate risk, cytoreductive nephrectomy is beneficial. So with this background and gross knowledge, let us see the series of evidences that we see as we go on. So this is what I was trying to say you. Risk stratification was just on paper until we had trials of nivolumab plus ipilimumab or cabozantinib coming in. And what they specifically said was, if it is intermediate or poor risk, giving cabozantinib or giving nivo-ipi, what we call as IO combination, are beneficial if it is an intermediate or poor risk. So to understand if the patient has none of the risk factors, then just a TKI is enough. Just sunitinib is enough. They will have a survival as good as adding an immunotherapy. Whereas if it's an intermediate or poor, is just a TKI is not sufficient to counterbalance that aggressive nature of disease. So there we need to pitch in and start them on some sort of immunotherapy or a very potential broad spectrum TKI like cabozantinib. So these are the evidences we have. If you look into the sunitinib registration trial, which is one of the landmark trials, if you look into the statistic design of this trial is looked into one of the trials where the statistic design is so good that all the trials are taking this as their reference. So you can see in the favorable group, the PFS is nearly 16 months. The moment you go to intermediate, it drops down to 10 months, and the moment you drop down to poor risk, survival is the progression-free survival is nearly 2.5 months. That is the significance of risk stratification. The how long the drug works or how long the disease can be under control depends on how aggressive the disease or to which category the disease belongs to. Again, similarly, in the checkmate trial, you can see the PFS is around 25 months in favorable versus 8 months in the poorest group, in the intermediate and poorest group. So so metastatic RCC is no longer a homogeneous disease; it is a heterogeneous disease. Uh, it looks like a single disease, but the behavior, the biology, the progression-free interval, and the resistance to TKI, how fast the disease progresses, how long the patient survives, all depends on how many risk factors the patient has. So this is the real-world data. I am going to just go through soon and just say the same fact again and again that the IMDC risk stratification, if you look into the time to treatment discontinuation, is also significantly different between the three subgroups. So the difference is almost, if you look into the difference, it's 8 months versus 15 months, and it's quite significant. Again, the similar one, you can see the response rates between the complete response or the partial response or the stable disease. You can see the difference between the three groups. You can see the disease progression in the poorest group. Nearly 50% of them progress. That is the best response you're going to get with a TKI. Again, the overall survival is quite significantly different among the three groups. So the risk stratification just divides the disease into three different subgroups. You can see the survival for a favorable risk group where there are no risk factors. It's nearly crossing nearly 4 years. Whereas the moment you come to intermediate group, it's around less than 3 years, and the poorest not even 1 year. This is how the Kaplan-Meier curves just suggest how bad the patient lives if it's a poorest group, if I'm treating the patient with single agent TKI. So on an average, if you put a figure overall for a metastatic renal carcinoma patient, the patient survives around 2 years. This is the number if I'm treating with only TKI. But if I take favorable group, it crosses nearly, I can say, around 4 years of survival for a favorable group, and then it drops down to 3 years and 2 years. So we all used to remember as 4, 3, 2. Favorable will survive nearly 4.5, and then the intermediate is around 3 years, and the favorable is around 1.5 to 2 years with the TKI. So what immune checkpoint inhibitors have brought differences in the intermediate and the favorable risk group category, intermediate and the poor risk category, where they're trying to this sort of aggressive nature of disease, like a shorter duration of from the diagnosis to start of therapy or the performance status. These high risk factors are balanced by using immunotherapy. So to proceed further, the series of data again stressing that in the intermediate group, if you have one risk factor versus two risk factors, again there is a difference. So intermediate risk category, as far as the IMDC is concerned, is not a single group. Again, they were classifying into if you have one or if you have two. So it makes difference. Again, so this is again the same real world data where it again stresses that patients, if the intermediate subgroup who had one risk factor had significantly lower hazard of death when compared to those who had two risk factors. So then going further, again the sunitinib in the Checkmate 214 trial, and this is the 42 months follow-up updated results. You can see the overall survival in the favorable group has not reached, and so in the favorable group, the overall survival is incomparable to the immunotherapy arm. So therefore, adding immunotherapy to the favorable group doesn't add much benefit, especially in Nevo EP. And then you have sunitinib in the intermediate and poor prognosis group. You can see the overall response rates. They drop down to 33%. So the overall response rates, survival, the progression-free interval, everything drops down the moment you drop down to intermediate and poorest category. So this particular real-world assessment of clinical outcomes among first-line sunitinib patients with clear cell RCC in the IMDC risk group. So you can see the favorable risk patients have a median overall survival of nearly 52.1 months, the CR rate of staggering 5.9%. And if you look into the intermediate with one risk factor, the median overall survival is around 35.1 months. So, what we can understand from this is in the favorable risk group and in the intermediate risk group, with one risk factor being there, a TKI like sunitinib is sufficient. Then coming on to the Adonis trial, which is published in March 2020, which is a recent data. This is a real world data in patients where they have used first line sunitinib and or second line axitinib post sunitinib progression. Again, so the analysis presented here includes the evaluation of sunitinib efficacy by the IMDC and the MSKCC criteria, and they did analysis for the IMDC risk with one risk factor versus two risk factors also. So they had clearly dissected the risk factors high, intermediate, low, and again the intermediate into with one risk factor and two risk factors. So they assess the efficacy and also the safety of sunitinib. The baseline characteristics are as per all the standard trials, and just directly come. You can see the median PFS for overall patients is 10.4 months, and the overall survival is around 34 months. The overall population treated first line with sunitinib. So this is the numbers. This is the real world data we have. So if you look into the overall population, the overall survival is around 34 months as per this Adonis trial. And the moment you classify them as per the IMDC, you can see the favorable group, the survival is around, the progression-free survival is around 23.8, and the intermediate is 11.8, and the poor it is 0.6. So the progression-free survival drops down as the number of risk factors increase. So nearly 2 years progression-free survival. In the intermediate phase, it's around 1 year, and poor risk it is nearly half a year. Again, if you look into the overall survival, again statistically different. You can see in the favorable risk group, the overall survival is quite significant. A patient surviving quite long just with the sunitinib, and look into the poorest, the overall survival drops to less than 1 year the moment it becomes poorest category. So this is again the MSKCC dissection, and then comes the IMDC risk dissection, again stressing that if you dissect the intermediate risk with one or two risk factors, again the survival is significantly different. So this is the Adonis trial PFS and the OS data in the favorable and in the intermediate one. So if you have the favorable risk or the intermediate risk with one risk factor versus other, you will have uh, the intermediate 2 versus 4, look at the separation between the curves. So ideally, the classification should be favorable on one side with intermediate risk with one risk factor on the other side, with poor and intermediate risk factor with two risk factors on the two sides. So if you have such a uh, if you have such a division, then you can see the curves how wide they are separated. You can see the a progression-free survival, then you can see the overall survival, how significantly different they are. So, if you look into the overall survival, in the favorable or the intermediate risk, it's 21.6 versus 9.4, so quite significant. So the Adonis trial had also looked into the safety points, and the points to consider again just the similar things. So PFS in the favorable risk in the overall survival in the favorable versus unfavorable, like the poor and the intermediate risk group with two risk factors, was statistically significant. So this trial again stressed the importance of dividing metastatic RCC into risk stratified categories. So this is again, so how much heterogeneous the intermediate group is with one risk factor and two risk factors. And this is another paper where the difference is much pronounced with one or two risk factors in the intermediate group as well. So presence of one rather than two qualifying IMDC risk characteristics suggests poorer outcomes. Again, you can see the difference with one or two risk factors. Again, in the mRCC subgroup, and this reflects in the overall response rates and also the survival. Again, going further, is it possible to improve prognostic classification in patients affected by metastatic RCC with an intermediate or poor prognosis? You can see the baseline characteristics of this study. You can see the prognostic factors 1 or 2, and the median overall survival drops down from 32 months to 20 months. And then the moment 3 risk factors are there to 10 months, and then 4 to 6.5, 6.9. So as the number of risk factors go on increasing, the survival reduces. So efficacy of sunitinib is better in favorable and intermediate risk with one risk factor group compared to the intermediate two. So again, the same thing has been repeated. This is one of the most commented trial as far as RCC is concerned. So before the publication of this trial, it was said that cytoreductive nephrectomy was the standard of care for all patients with metastatic RCC. So even if the patient had multiple risk factors, they had bone mets, multiple lung mets, even then, before recruiting them to clinical trials of, in fact, interferon with bevacizumab or TKI, cytoreductive nephrectomy was a mandatory thing. But this particular trial, the Carmina trial, which was published, this actually changed the whole thought process of how to look into cytoreductive nephrectomy in the era of TKI or in the present era. So, is cytoreductive nephrectomy really required in a metastatic RCC? So, there were some anecdotal evidences that even in a metastatic RCC, if we do a cytoreductive nephrectomy, the metastatic sites will undergo spontaneous resolution, and therefore there was some justification of doing it. So Carmina trial was a very fairly performed trial with whatever comments and connotations it has. Clearly said cytoreductive nephrectomy should not be performed in any metastatic RCC. But later on, the trial was commented, dissected, and there were multiple comments saying that this particular trial included majority of intermediate and poor risk population. That's the reason why it doesn't benefit. So on further dissecting the trial, we came up with some conclusions like in the favorable subgroup, cytoreductive nephrectomy is beneficial. Whereas in the intermediate subgroup with one risk factor being present, again cytoreductive nephrectomy is beneficial. So this is one of the rare trials which are performed to address the issue of surgery in mRCC, and this came up with excellent practice-changing results where we should not be doing cytoreductive nephrectomy in patients who have poor risk and in those patients who have intermediate risk with two risk factors. Again, there are finer details of this. I will dissect into them. So this is the one. This is the patient characteristics and the number of IMDC risk factors. You can see intermediate risk factors 1 and 2 if they are present. You can see arm A and arm B. Arm A is nephrectomy plus sunitinib and arm B is sunitinib alone. This is the number of patients that we had, and this is the risk factors, and this is how well balanced they were, and this is the results. This is a very important and informative table. You can see arm A is nephrectomy plus sunitinib, and arm B is sunitinib alone. You can see the median survival. If there is one risk factor, it is 31 versus 25 months. Even though the statistical significance is not there and the hazard ratio is crossing unity, there is some numerical advantage in the IMDC if there is one risk factor. The moment if you see if IMDC has two risk factors, the whole thing reverses. But those patients who do not undergo nephrectomy are surviving longer, therefore surgery is not doing much. So, cytoreductive nephrectomy might be beneficial for patients with only one IMDC risk factor, especially in cases of one metastatic site per se. So, if there is good risk and if it's intermediate risk with one risk factor, and if there is one site of metastasis, in these select subgroup of patients only we should offer a cytoreductive nephrectomy. If it's poor risk or intermediate risk with two risk factors, we should not be offering cytoreductive nephrectomy in this set of patients. So whatever evidence we have is in the era of TKI, but in the era of immunotherapy, we don't have any such evidence. So when there was no active systemic therapy, like in the era of interleukins, interferons, yes, cytoreductive nephrectomy did give survival advantage. The moment we came to the TKI era, we are saying in the favorable group and in the intermediate group with one risk factor there is advantage. And the moment we come down with immunotherapy, again the scenario may change. If there's a trial performed, maybe cytoreductive nephrectomy will become almost obsolete. So it is more of a systemic disease, and if you have effective therapy, then local therapies won't matter. The similar thing, the way we had in Hodgkin's, where radiation was used more and more, and the moment you had better systemic therapies, then radiation slowly took a back foot. So the similar thing happening if you have very good systemic therapy, the local therapy will become less important. Again, real world outcomes in patients with mRCC, the START registry, again, saying the similar things. Risk stratification is important. Again, divide them into three categories, and then coming on more, age is not a criteria. Again, elderly age, we can offer better anti-cancer therapy. And this is one important thing. If you have sarcomatoid features, immunotherapy does wonders if there is a sarcomatoid variant. Otherwise, the sarcomatoid, we didn't have much evidence before these immunotherapy trials were there, and then subgroup analysis of these immunotherapy trials, especially addressing the sarcomatoid variant, has brought into light that immunotherapy works extremely well in the otherwise poor prognosis sarcomatoid malignancies. You can see the progression-free survival in the intermediate and poor risk category. The PFS is 8.4 versus 4.9. The significant difference in the p-value and the hazard ratio of 0.6. Again, the overall survival is also significantly different. Whenever we have an intermediate or a poor with sarcomatoid features, we should be subjecting them for some sort of immunotherapy. rather than a TKI alone. Again, another similar evidence saying that sarcomatoid immunotherapy has greater implication. It basically balances the poor prognostic nature of the sarcomatoid variety. So this is one. These are certain comments. If I am using a immuno, if I'm using immunotherapy alone or an immuno, there's a risk of pseudo progression. And if there is a tumor sitting next to spinal cord, and if I use only immuno, then there may be pseudo progression and causes cord compression and all this. Uh, Possible in pseudo progression itself is rare, and having a scenario like this another rare scenario, but we can keep this in mind. So to balance this, if we can combine an immuno with a TKI, like a Pembro Axi combination or Avelumab Axi combination, we can overcome such scenarios as well. So this is the difference between using a TKI versus an immuno-oncology. Of course, the experience with immuno is less, but now we are gaining more experiences. We are learning that it is easier to handle immuno, but however, in a very small subset of patients, we need to be having a very low threshold to start them on steroids, stop immunotherapy, be aggressive to, to get the immunity in control. So we also have seen, and those patients who have grade 3, 4 toxicities with immuno-oncological drugs also do well in spite of stopping immunotherapy treatment. So in the today's era, we can see the different guidelines suggesting. So overall, to summarize simply, good prognosis or a good risk patient, if we have TKI like a sunitinib or a pazopanib is sufficient. No need of giving immuno-oncology drugs in the good risk setting. The moment you come down to intermediate risk setting, there I need, and in the poorest intermediate and poor, I need to put in an immuno or immuno TKI combination in the intermediate and poorest category. So this makes a lot of sense. And that's the reason why IMDC classification is not just prognostic, it is also predictive, and it will help me to choose which modality of treatment I'm supposed to use. Should I offer cytoreductive nephrectomy to the patient or not? So with this, I would conclude saying that so immunotherapy, that we need to do IMDC classification for all metastatic RCC patients. We need to classify them into low, intermediate, and a high risk or poor risk. And intermediate should be further classified into intermediate risk with one risk factor and with two risk factors. Those who are having good risk, TKI alone is sufficient. The moment you come to intermediate and poor risk, then we need to add some immunotherapy in the first line, either immuno or immuno TKI. Immuno, if you look into Novo EP, there is a staggering 10%, 11% complete response rates if you use this drugs. And then cytoreductive nephrectomy, good risk you can do, intermediate risk with one risk factor or single metastatic disease, it may be done. Whereas if it is poor or intermediate risk with two risk factors, cytoreductive nephrectomy should not be done. With this, I would conclude, and I would thank Pfizer for again for providing this opportunity. Thank you.